I'd like to start by thanking Dr. Weissman for that very kind introduction. It is truly a privilege to be here. I've enjoyed being in Brazil for the week, and I've been able to see your beautiful country and really have enjoyed my time here. So thank you for your hospitality. I'm going to talk about obesity and thyroid cancer. Hopefully my slides will come up soon. There we go. Okay. So I'm going to talk to you about obesity and thyroid cancer. Just in the way of disclosures, I am on the advisory board, a consultant, and a speaker for Genzyme. I don't believe that that relationship will impact this talk in any way. So I know that we've already talked about the rising incidence of thyroid cancer in a very eloquent talk earlier, and some of my slides do actually overlap, which may be a good thing, that perhaps we're all agreeing that these studies are important. I might present a slightly different spin, I'm not sure because I don't speak Portuguese, but I did see some of the message there. I'll try to skip through those slides and not cover them too much. We're also going to talk, of course, about the association between thyroid cancer and obesity. These studies, as you will see, are very diverse, and they're not very strong studies. Any kind of association study is naturally a difficult study to perform in humans, and as a result, the studies are a reflection of that. We'll talk a little bit about the etiologic mechanisms of development of thyroid cancer and obesity and how those two might be linked. But that in and of itself is an hour-long discussion, and the end result is we really don't know. And then we'll talk a little bit about obesity and prognosis in thyroid cancer, and then close off with just some future directions for research and where we should be heading in our understanding of this relationship. So the incidence of thyroid cancer, as you all are well aware, is rising. This is a study, of course, of the United States, and the reason I like this study is because it shows the prospective increase in the thyroid cancer incidence moving forward, and what they are projecting is that there will be a doubling in the rate of thyroid cancer diagnosis, such that it will become the third most common cancer in women in the United States. So of course this is alarming, and of course it's also associated with a very large increase in expenditure of healthcare dollars, such that anyone diagnosed between 2010 and 2020 will have, between the diagnosis, treatment, and follow-up, that will be associated with a $10 to $19 billion cost, which is a huge, in US dollars, of course, a huge number. And so in the US, we're very alarmed by this and trying to understand better why this is occurring and how do we stem this bleeding of our healthcare dollars. As you can see in the bottom of the slide, or the graph, there is a pretty stable incidence or mortality rate. We're going to talk a little bit about that mortality rate and survival data because it seems to be conflicting in various studies. We know that the incidence rate is rising in both men and women, and it's rising in all ages. So this is not just an issue for our adult physicians, it's also an issue for the pediatric endocrinologists as well. As you can see in this study, those aged between 15 to 20 are certainly seeing an increase in the incidence of thyroid cancer. And we're seeing this as well in all races. So historically, Asian Pacific Islanders had a higher rate of annual increase in thyroid cancer incidence, and it was thought to be dietary related. Now we're seeing that non-Latino white people are at the highest annual percent change in the increased rate of thyroid cancer, such that the annual percent change for non-Hispanic whites is about 5.6%, and African Americans, the annual percent change is 4.8%, both of which surpass the rate in Asian Pacific Islanders of 2.3%. And we know that, of course, the discussion about increasing detection, 16% of CT scans will diagnose an incidental thyroid nodule. 75% of those are less than 1.5 centimeters. So certainly there is an increased detection going on, as you've heard from the earlier discussion. This is a linear regression analysis to really look at that relationship between CT volume and the incidence of thyroid cancers, broken down by tumor size. And you can see that the line with the largest slope, or the strongest relationship with CT volume, is those tumors under the size of 1 centimeter. Now, probably most of these tumors were not diagnosed on the CT, but rather another nodule in the thyroid was diagnosed, or perhaps a calcification was diagnosed within that thyroid that led to the ultrasound. But the tumors that are being discovered at the greatest rate are those that are less than 1 centimeter. And this is a very strong relationship. This R value, you can see, is highly significant. Now, we know as well that this is going on across the world. Of course, it's going on in Brazil, it's going on in the US, it's going on in Europe. And this is a study looking at the incidence rates over the last 40 years, and you can see that there is a significantly increased rate in all of those countries. This study also looked at increased rates of detection, and they concluded that the expected rate of thyroid cancer detection, they subtracted that from what they're actually seeing, and they found that there was about a 50 to 60% increased rate of diagnosis of thyroid cancers above what was expected. And so they concluded that that was from increased diagnostic scrutiny, such as increased imaging. Now, you could also argue that that's because we're also having some other phenomenon that's going on that's causing these thyroid cancers. They didn't necessarily prove that this is because we're doing more imaging. We know from the Korean data, you saw this data earlier, we know from the Korean experience that when they introduced this national thyroid cancer screening program, the rates of thyroid cancer went up 15-fold. And you can see that when they instituted that change, that increase in incidence occurred pretty dramatically and quickly. But their mortality stayed the same. Recognizing that this was an epidemic of overdiagnosis, the physicians in the country said, let's put a halt to this. We need to turn this around because we're not improving our outcomes in our patients. And so they published a series of articles, and there was a television broadcast to say we don't need to be screening for thyroid cancers. And as a result, there was a 35% reduction in the number of thyroidectomies that were performed after that televised call to stop screening. And we know as well from numerous autopsy series and surgical series that there is a reservoir of undiagnosed thyroid cancer. When we do autopsy studies, we can find up to 35% of patients have small thyroid cancers. You're well familiar with this data. But not all cancers are incidental cancers, and not all the rise is occurring in those incidental cancers. And this study showed that the cancer rates are going up even for larger tumors, suggesting again that yes, overdiagnosis may be playing a role as we see this rise in the greatest amount of rise in the small tumors, but we're also seeing a rise in the larger tumors, and those probably are not as much of an overdiagnosis as true disease. You saw this study as well. This is just highlighting, again, the increased incidence around the world with stable or improving mortality over time. And this is highlighted in a recent study at the Memorial Sloan Kettering in New York, looking at the SEER database, which is a database of US patients, from 1983 to 1999, what we observed was a 10-year relative survival improvement from 95% to 98%, and that was statistically significant. The Sloan Kettering also saw an improvement in their survival between 1950 to 2005. It was not statistically significant, but the trend was clearly visible. So you can see that parallel trend in improved relative survival. Now, the authors warned that that may be a reflection of an influx of increased diagnostic scrutiny, such that if we flood this population of patients with small microcarcinomas that are relatively indolent and have an excellent survival, then we're diluting out the sample. And so they found this when they stratified the tumors based on size and stage, that there was no change in survival over time between 1950 and 2005, or between 1983 and 1999. So this suggests that there's not an actual improvement in survival, but rather we're seeing more cases of low-risk cancers, and that's making the overall survival look better. So the point of my talk, of course, is why are we seeing this rise? Well, I'm going to talk about one potential mechanism. Of course, there are many, many others. So when we look at the incidence of thyroid cancer and we superimpose the incidence and the rise in rates of obesity, you can see that these two parallel each other quite well. And in the US, incidence rates of obesity have doubled in the last 40 years, 50 years. And in teens and adolescents, the incidence of obesity has tripled. So we know that this is an epidemic. And you can see that these two lines are fairly parallel. And this is, of course, data that you're all familiar with if you've been to any diabetes lectures or insulin resistance lectures. The prevalence of obesity worldwide is increasing as well. And so the top figure is for men, the bottom figure is for women, and you can see that across the globe, we are a large group of people, with the exception of a few small countries in Africa, where it's generally very thin patients who probably are malnourished. So when we look at meta-analyses, and numerous studies have looked at this. This is a meta-analysis of 21 studies, including over 12,000 patients. I'm not going to try to stratify each study, so I think a meta-analysis is the best way to look at this, because there are conflicting results depending on the study that we are evaluating. Some studies show there is an association between thyroid cancer risk and obesity, and other studies show that there is not. But in general, the meta-analyses, I think, are the best way to look at this. So this was the first study looking at obesity risk thyroid cancer risk and obesity, and it's a prospective study of 5 databases, and what they found was in over 1,100 patients, there was an association between increased risk of thyroid cancer and obesity, depending on the quartile of obesity. These were self-reported results, so patients were in a database and they self-reported their height and their weight, so there's an inherent limitation with that, because we all like to think we're thinner than we really are. So that is a little bit of a limitation. And we all like to think we're taller than we really are, except for me. I really know I am very tall. So, but with that in mind, you can see that there was a statistically significant increased risk of thyroid cancer. So about a 20% increased risk of thyroid cancer, and this is for men and women, and those who were considered to be overweight, and then about a 50% increased risk of thyroid cancer in those who were obese. And this is a US study. Now, this is a worldwide study, so this is a meta-analysis of 21 studies with over 12,000 patients. and looking at underweight versus thyroid cancer risk. And it's important to look at men and women separately because we are different, and we'll talk about that a little bit more as we go on. But in this study, there was no significant association between underweight and underweight and thyroid cancer risk in men. But in women, there was a significantly reduced risk of thyroid cancer in those women who were underweight. But it's important to look at these p-values. It's not statistically significant in terms of the study variability. So there's a lot of heterogeneity in these studies, suggesting that there may be some bias in that. When we look at overweight, so a BMI of 25 to 30, there was a almost 30% increased risk of thyroid cancer in men who were overweight, and a 27% increased risk of thyroid cancer in women who were overweight. And then, of course, with obesity, there's an increased risk above that, so a 50% increased risk in men, but you can see that this crosses unity, so it's not statistically significant. And in women, it was statistically significant. You can see that the confidence interval here does not cross unity. Now, this study also looked at other variables that maybe BMI is not the entire story. Maybe we need to look at anthropomorphic features. So waist to hip circumference. Do we need to be looking at the amount of abdominal adiposity that a patient has? And so you can see for every 5-unit increase in BMI, there was a 30% increased risk of thyroid cancer. For every 5-kilogram increase in weight, there was a 5% increase. And then for waist circumference, for every 5-centimeter increase, you saw a 5%, and hip circumference, a 5% increase. So maybe we need to look at other factors other than just the BMI, and several studies have upheld this relationship. And as well, this study also looked at, does age at the time of onset of obesity matter? So the younger you are when you become obese, does that impact your risk of developing thyroid cancer? And the answer is some studies say yes, that when you are closer to age 18 and become obese, then you have a higher risk of developing thyroid cancer later. Other studies say no, it's more important around the perimenopausal time, obviously just in women. So there's not a really clear indication of what we should be looking at in these studies. And so this perhaps can explain some of the diversity of the studies that are showing that yes, there's a relationship, and no, there's not a relationship in the same population of patients. They also looked at histologic subtype in this meta-analysis and found that patients who were overweight were at a higher risk of developing papillary thyroid cancer. And it was actually, being overweight was protective for those with medullary thyroid cancer. So being overweight reduces the likelihood of developing medullary thyroid cancer. And then when we look at obesity, you can see that papillary and follicular thyroid cancers were a higher risk. And then medullary was again found to be, it was protective being obese. And then anaplastic was also statistically significant in this meta-analysis. Now, you can argue that in obese patients, they're maybe more likely to utilize the healthcare system. So an obese patient may already have diabetes, or may have hypertension, or may have chronic osteoarthritis, therefore causing them to seek more medical care. And as a result, maybe we're finding more cancers in those patients. And this is biasing, an ascertainment bias in our studies with the meta-analyses. So this is a Chinese study looking at screening patients for thyroid cancer, and then going back and looking at how does the obesity interact with the risk of having thyroid cancers. So you can see this is a study looking at 15,000 patients, and again, this is in China, so it's important to remember that Chinese is not the same, obviously, as in terms of incidence of obesity as you would see in the United States, and they were a blue country, meaning they were thinner than we were in the United States and here in South America. But when they did see obese patients, their risk in women was higher of having thyroid cancer. Now, they only diagnosed 267 thyroid cancers in this case study, but there was a 1.6-fold increased risk of thyroid cancer for every 5-unit increment in BMI. So an increased risk when we're screening, but this is only the case in women, not men. So how is this interaction, how is it that obesity causes thyroid cancer, if it does in fact cause thyroid cancer, if it has a role in the development of thyroid cancer? And you can see from this slide that it's intentionally pretty complex, and there's no clear-cut answer. I'll cut to that chase. But we can imagine that insulin resistance, of course, plays a role. So higher insulin levels with obesity are pretty well established. And as we know, insulin is a growth factor. There are insulin receptors on the thyroid cell. And so you saw some data earlier looking at the insulin resistance theory in development of thyroid cancer. Also associated with increased insulin levels, increased IGF-1. And IGF-1 is also a growth factor, just by its name. And there have been some associations there with IGF-1 and causing thyroid cancer. And then, of course, the whole argument about height and thyroid cancer risk. We know as well there are various inflammatory markers that go up with obesity, so adipocytokines, alterations, and various markers of inflammation increase, and that perhaps may cause an increased risk of thyroid cancer. And another important factor that I have that's not really covered on that last cartoon is leptin. And leptin is a really intriguing hormone in that it is leptin receptors are present on the pituitary gland. They are present near the TRH nuclei in the paraventricular nucleus. There are TSH receptors in adipose tissue. So we know that leptin goes up with feeding and goes down with starvation, and that the leptin circadian rhythm secretion actually is directly superimposable with TSH secretion in the circadian rhythm. So those two seem to be pretty intimately linked. Also, there have been studies showing that injection of recombinant human TSH in humans causes a proportional rise in leptin, proportional to the person's BMI or their adiposity. And as well, if you infuse leptin during a fasting state, it blunts the rise, the normal rise in TSH secretion. So there's clearly an interplay between leptin and TSH, and what that mechanism is potentially in causing thyroid cancer is not clear, but that's been posed as another possible mechanism. Okay. So we'll finish up with Prognosis. This is a study that was performed at my institution looking at a group of patients with 259 patients with thyroid cancer and comparing them to their age-matched controls. And we looked at the presence of nodal metastases and tumor invasion and tumor stage and other markers of aggressiveness, so vascular invasion, extrathyroidal extension. And how did that correlate with BMI of the patient? And you can see that there was no statistically significant relationship between BMI and features that portend a worse prognosis in thyroid cancer. The unity line here is this dashed line, and all of these confidence intervals cross the unity. However, you can see that there was a trend toward actually looking like it was a better prognostic indicator to have obesity in terms of thyroid cancer outcome, and these more obese patients here had a better odds ratio, and an odds ratio less than 1, though it did not reach statistical significance. So when we look at other studies looking at BMI and tumor markers of aggressiveness, you can see in this study that was done in Korea, the BMI was associated with a 30% higher likelihood of having a larger tumor. Microscopic invasion was statistically significant, and advanced TNM stage was more likely in patients who were obese. Now again, this is a Korean population, and the number of patients who were obese was pretty low. And then in this study, also out of Korea, they found that there was no statistically significant difference in outcomes. It did not impact recurrence-free survival, extrathyroidal extension, tumor size, or any other markers of more aggressive disease. So it may improve prognosis according to our group. It may have a worse prognosis according to one Korean group, or there's no effect according to another Korean group. So that's about as clear as mud. And I apologize, but that's the best data we have. So I'm getting the sign that I need to quit talking, so I'll just finish up by just discussing a few future areas of research. So the question is, are we measuring the right variables? We shouldn't be treating men and women the same, so we need to separate those two groups because we're clearly different. Should we be looking at the time of onset for obesity or duration of obesity? Should we be looking at waist circumference, abdominal adiposity? What factors should we be looking at? We should, of course, be aware of ethnic differences. Is an African American the same as a non-Hispanic white, or is that the same as a Hispanic patient or an Asian? Does age matter, or the onset of obesity matter? And so these are the things that we need to consider when we're looking at future studies. We need larger studies, perhaps in each population of patients, to further clarify the question of, does obesity matter in Latin Americans, or does obesity matter in Americans, and looking at the various other factors that we've discussed. And so with that, I will close. So thank you.